So that's a tough act to follow, Dr. Nishant. So I'll just speak a little bit about the real-world evidence. So like Dr. Lalit just said, the clinical trials are based on these strictly defined protocols. And they have a lot of exclusion criteria, which we may not see in our patients, like patients with poor glycemic control, active PDR, etc. So in the real world, these patients are what actually come to us. So the protocol which strictly determines time frame for follow-ups, all this may not be so relevant for our setting. So although we are going to translate the clinical trials to our kind of clinics, let's look at the efficacy of the intravitreal Aflibercept for treatment of center involving DME in a real-world setting. So we just heard from Dr. Nishant the key messages from the clinical trial. Aflibercept is indeed the choice of treatment for patients' vision acuity worse than 69 ETDRS letters. That's less than 20/40 due to DME. And this has been shown by Protocol T, and there's no doubt about it. The molecule has been designed to trap VEGF and PGF, which occur at very, very high levels in these diseases and have a pathology and are important for DME. So this is the reason why. There's also a disease-modifying role, which is important when we use this molecule. And as we just learned in great detail, intensive treatment in year 1 can modify the underlying disease and improve the long-term visual outcome. So now, along with this trial, let's see what is the real-world evidence which is emerging, which will kind of support this and help us in our clinical practice. So I think the company also is supporting multiple real-world studies, and these, as you can see from this slide, they are across the world. There's none from India, so when I pointed out to Dr. Prachi and team, they said they would consider it, but there's none of these right now currently in India. So there's good evidence from one of these trials which was held in France, and this showed that treatment-naive patients who received the 5 initial doses of Aflibercept gain numerically higher vision gains than those who don't. So this is what always we were taught about the pathology, that initially you have to give 5 injections, and this is supported by the real-world evidence. I think Dr. Nishant just spoke about this. This was at the Moorfields Eye Hospital. And again, even these authors say the purpose of the clinical trials, that there are various reasons. Patients may have multiple doctor's appointments. They are the diabetics, unlike the AMD patients, are the working age group population. So they don't comply strictly. And they did this trial because the strict regimen is not possible to replicate in the real world. So they wanted to kind of find a way to pragmatically deliver effective therapy, which was practical for their patients. So even this trial showed that Aflibercept was associated with meaningful vision acuity gain and avoided loss of vision in the real world condition. And what they found also, which is interesting, that patients who presented with poor baseline visual acuity are constituting the majority of patients who come to our clinic. So they kind of echoed what Protocol T showed, but that also in a clinical setting and not in a clinical trial. The visual gain also was excellent in all the groups, and this is what Dr. Nishant also showed, the wow factor. In the first year, 7.6 injections were the mean number, but just look at the data after that. 12 to 24 months, only 2.7, and 24 to 36 months, only 2.9 injections were needed. So hit it hard initially, and you'll reap the benefits later in year 2 and year 3. I think that was a kind of pivotal message from this trial. There's also an interesting FRB, the Fight Retinal Blindness Registry, which is there in Australia. And they also kind of compiled this data of patients who had less than 68, so that would roughly be 20/40. And they also they compared the two molecules, ranibizumab and Aflibercept, and they found significantly greater vision gains in Aflibercept. You can see this is a plus 7.6, whereas this was plus 10.6 letters. So now we come to an RCT. So this is, of course, the highest level of evidence. So this was a RCT published in the Cochrane database review. And this included a large number of patients. There was more than 6,000 patients, 24 studies. And they found that at year 1, all efficacy outcomes favored Aflibercept over the other molecules. Patients were approximately 30% more likely to gain more than 3 lines with Aflibercept compared to other molecules. And for every 1,000 patients with aflibercept, 92 fewer would gain 3 or more letters. So this would be roughly 10%. So even a 10% patients doing better than the other molecules is a significant number. So again, this is another slide based on the Cochrane metadata, the database. So they said they were more effective. Of course, first they compared these to laser. So all the anti-VEGF agents are more effective than laser at improving vision. This is no rocket science. I think we all know that. Patients receiving aflibercept are more likely to gain more than 3 BCVA at 1 year compared to the other molecules. And I think at 1 year, patients receiving either ranibizumab or bevacizumab had lesser change in vision and lesser CRT change compared to aflibercept. So here you can see that ranibizumab versus bevacizumab seems almost same, whereas aflibercept is superior to both these other molecules. So the certainty that they are more effective than laser, that is high, whereas the fact that ranibizumab and bevacizumab did not differ is moderate. What do the various retina societies across the world say? So these are some guidelines from Euretina. There are some guidelines from Australia published in Clinical and Experimental Ophthalmology, guidelines from Canada, and guidelines from the German Society. The Euretina guidelines provide expert opinion regarding this, and they have said the use of ranibizumab was most likely to result in the same activity after 2 years as aflibercept, so this is similar to Protocol T. But the effect will be reached in a slower manner. So therefore, they recommend it should be started with aflibercept if it is available for these patients. So again, similar message that if it's worse vision eyes, we should start with aflibercept. This is some data by Dr. Jamie Chung's group, and this is Asian data. And this is based on evidence-based collected from Asian country. So the message is quite clear. The choice of the anti-VEGF should depend on the baseline visual acuity. And again, similar to what they said with Protocol T. And the key message, I think, which Dr. Nishant and I have, again, and I'm trying to say that early intensive anti-VEGF is important for patients in Asia as it is across the world. The ASRS PAT survey is annually done by the American Society of Retina Specialists, and they had participants from 42 retina societies across the planet participating in it. And even they found that aflibercept is considered a treatment of choice for even new onset DME if the cost was not an issue. We all look up at the DRCR net because this is not a strict clinical trial. Some way they also recruit from private practices across America. And it is the fact that aflibercept is recognized as standard of care for DME is the fact that DRCR net also recognizes it, and it is using it in all its pivotal trials which are coming up now. So to summarize, aflibercept is treatment of choice for patients with visual less than 20 by 20, as demonstrated by Protocol T, by the guidelines from society, and by some of these real-world evidence studies. Importance of early intensive treatment, so treat it early, treat it hard, and then you can get robust long-term improvements in vision, and you can reduce the treatment burden to these patients who are in the working age population, so that you can improve the quality of life in subsequent years. And when costs are not an issue, this is a kind of drug of choice for patients even with new onset DME. Thank you so much.